Good morning, everyone. Today, my topic is using implementation research, which is a relatively new concept, to strengthen the integration of non-alcoholic fatty liver disease into the National Program for Prevention and Control of NCDs. So, ILBS played a key role in taking this groundbreaking initiative in 2021 for integration of NAFLD into the National Program for NCDs. And the guidelines, operational guidelines were launched in February month of 2021. And this made India at #1 amongst the scoring for the fatty liver preparedness scores among 102 countries. But even after 2 years, there is no yardstick to measure the extent of implementation of this integration into the program. And any program's inadequacy can be because of technical, administrative or operational incapacity at various levels. So we do not know the exact facilitators and barriers in the implementation of this integration. It could be at the level of poor communication about the benefits of health due to lack of awareness, or poor use of healthcare informatics at the state levels, insufficient management training, lack of financial resources or political commitment, and limited collaboration with other healthcare organizations. So recently, last month, ILBS collaborated, is working with this government of Jharkhand for implementation of this integration. We aim to strengthen the integration at different levels of healthcare, primary, secondary and tertiary, in 2 districts of Jharkhand, Khunti and Lohardaga. And we aim to strengthen the facilitators and overcome the barriers, and also do the capacity building of staff with specifically designed training plan as per the program at all levels of healthcare. So for the past 1 month, we met with Additional Chief Secretary at Ranchi, Jharkhand, presented the need for strengthening this integration to improve their capacity of health system for screening and referral of NAFLD patients. This was in first week of July. So the stakeholders were Government of Jharkhand, State Nodal Officer of this health program, representatives from all the 6 medical colleges from the state, MD, NHM, WHO representatives and ILBS Delhi. So 3 days later, they announced that they will be starting the screening for liver diseases under the program. Then they called up for the follow-up meeting 10 days later for within their with the stakeholders for this health program, and briefing of district nodal person, district program manager, NCD staffs, and taking up screening of NAFLD as well, along with other diseases that come under NP-NCD program. And just recently, 3 days back, they announced that this they have actually released this official order to start this screening of NAFLD in 2 of their districts on pilot basis in Khunti and Lohardaga districts from 1st of September 2023. So all the training capacity building will be concluded with ILBS till 31st of August. So what we aim to do there is the basic community level screening with what we call ASHA workers, they call Sahiyas in Jharkhand. So they will identify high risk patients based on, they have a community based assessment checklist CBAC form. As we call it, we presented that they just have to record the waist circumference for initial screening and referral at the community level. And with or without the history of diabetes or hypertension, liver diseases, gallstone, etc. This is as per the guidelines of the national program. So if there is a history of diabetes and or the waist circumference is more than these cutoff levels, they need to refer the person to PHC level or sub-center at first. So we sub-center pe health worker will we also call as community health officer there. So the health officer will validate all the individual referred by the Sahiya in these 2 districts, and will again check the waist circumference and their BMIs. So the training whole training program has been finalized, which will be implemented by 31st of August this year. Then they will refer to the primary healthcare. So there they have set one specific window for the blood sample collection sorry, not at PHC but CHC level, but at PHC, medical officer will examine the patient referred by ANM, and waist circumference, BMI, and all the family and personal history will be recorded. And then any patient with abnormal LFT, especially high ALT, history of diabetes, or any history of hepatic steatosis on ultrasound will be further referred to CHC level there. So here the ILBIS has also offered the facility for teleconsultation at PHC and CHC level, so that these patients from these two districts can avail the specialty consult at various levels. So at CHC, they have set up a specific window for the health program, especially for NAFLD patients who will conduct these basic tests. And medical officers will be trained to calculate the FIB4 or NFS scores based on these tests. And they have a facility of ultrasound at CHC level, but they were also open to recruit one person and the fibroscan machine. And the fibroscan machine will be acquired on lease, and payment will be made to the company on per test basis. So this is the whole flowchart of how the patient will flow from primary healthcare level. If FIB4 is less than, I mean, this all is as per the national program, low risk, so LSM and exercise, and maybe repeat evaluation after a year. And if FIB4 is more than these cutoff level, then they'll be referred to the higher center, CHC or district health level. And fibroscan, if they are able, they will be acquiring on lease, so these values, and then further the flow. So the role of implementation research at this stage, so we were able to get the official order based on the political will as well as the technical support from ILBS. But role of implementation research at this point is to bridge the evidence into action gap. So implementation research has three cornerstones. One, who is implementing, the implementer of the policy, the consumer, who is the end user, and the context, the contextual settings. What will be working in Delhi will not work in Jharkhand and maybe in Rajasthan and so on. So in implementation research investigates the various contextual factors that will affect how a new policy or intervention may be implemented in the real life settings. So after we roll out this program from 1st of September, we are aiming to investigate all aspects of implementation, including the uptake of evidence-based policy and activities used to put these into practice, factors that will influence these activities, and the impact of these factors on health outcomes. So the questions addressed by implementation research will be: which policy is best for a new context? What is the best way to implement it? How can the target population be reached? What factors might affect the implementation and adoption? How can the costs of implementation be minimized? And how can uptake and health outcomes be improved? So why is implementation research important? So implementation research involves the scientific study of the processes used to implement the policy and the contextual factors. So to implement the intervention in context, which is very important, where population or resources may differ from state to state or district to district, from that where they were initially formulated in a ideal setting and evaluated, and then we help identify which components of that policy are needed to obtain the intended outcomes. So there can be two levels of failure: intervention failure or implementation failure. So it may be after we roll out the initiative, we will get to know that whether the intervention was ineffective in that setting or whether it was being deployed incorrectly. So this is the core diagram for implementation research. So we once the guidelines were released and integrated, the step one was already achieved. The identification of the appropriate intervention. So this intervention was selected, assessed, and evidence was identified. So these NAFLD guidelines were integrated. So this has already been done. Now we are at step 2, adapting and piloting of this policy. So how will a policy and intervention for a new setting will be refined and translated? So we have to synthesize the knowledge and then translate it, collate and translate it. And then we have to study how acceptable will this intervention be at the district level, and what will be the barriers and facilitators of implementation, for which various study designs are there for implementation research. Then after piloting this intervention, next step will be to evaluate the implementation of this intervention, and for this there are various outcome variables, 8 outcome variables to study. What is the reach of this intervention? They have just released the order, but what will be the reach? What will be the adoption at the community level? And how well the policymakers will be able to implement it? And how effective will the implementation be at the end? And then final, it is the scale up of policy for sustainability. So if the policy intervention is appropriate for new context, and what resources need to be mobilized to scale up the intervention, and how will this knowledge be translated and exchanged effectively. So these are the various specific study research methods for implementation research. So first are the pragmatic trials. Pragmatic trials are a bit different from the routine randomized control trials, because they look at the efficacy of an intervention. The conventional RCTs look at the efficacy of an intervention in the ideal or control setting, whereas the pragmatic trials are also called as practical trials, in which the main research question focuses on the effectiveness of an intervention in a normal practice setting. But the star research method in implementation research is effectiveness and implementation hybrid trials. So this is the usual study flow. First is the efficacy study in the control setting, effectiveness studies, and implementation research. So hybrid design lie in effectiveness in implementation, so that effectiveness study and implementation goes side by side. And then other research methods are quality improvement, participatory action research. Participatory action is carried out with and by the local people rather than on them. And then the standard mixed methods. So these three type of hybrid implementation effectiveness implementation hybrid trials are of 3 types. So type 1, type 1 and 2, they focus on the effectiveness of intervention, and the secondary outcome is to understand the context for implementation. But what we usually do at community level settings is type 3 hybrid, which will focus primarily on the implementation outcomes, like testing of implementation strategies, while also collecting the effectiveness outcome. So what we are trying to do with the Jharkhand model is type 3 hybrid effectiveness implementation study. So we will know to what extent the policy will be implemented as it was intended. It is also known as the fidelity of the policy, like it is being implemented as it was intended, and to what extent was the policy adopted by implementers. So for this, we'll be studying various quantitative indicators, like the number of forms filled at various levels. So we have total 6 forms in the National Health Program at various levels, sub-center, PHC, CHC, up till district levels. And we will also, like a training program has been set, scheduled till 31st of August. So we will be taking into account the number of trainings at all levels of healthcare. So another expected outcome will be the most effective techniques to incorporate this integration into actual care delivery at various levels. And finally, how do contextual factors, which is the key in implementation research, to influence the implementation success and failure. So these are various implementation outcome variables which we have related to Jharkhand model. There are 8 outcome variables. The acceptability of it, the perception among stakeholders, where political will played a key role, that the intervention is agreeable and they will be able to incorporate and integrate it into their existing programs. Adoption, the intention to try to employ this new intervention. The perceived fit, the appropriateness or the relevance of intervention in their setting. The extent to which the intervention can be carried out in a particular setting. The fidelity of it, already as that it was implemented as it was intended in the original guidelines or policy, and the various costs, direct, indirect costs for the implementation. Then the outcome is also to check the coverage, who percent of their population they are trying to target through this. So degree to which the population is eligible to benefit and who actually receive it, and then the sustainability of the program. Examples to check the social validity of a policy or intervention which we'll be using in implementation research. What are the problems you think are common in this community? Which problems do you heard of fatty liver before? If so, what all do you know? And if someone has fatty liver, do they do anything about it? This is the social significance of goals. Socially acceptable procedures are for the community health workers. How do you feel about seeking health advice from your community health worker? How good or bad are community health as a source of knowledge about your health? And how do you feel about information sessions organized and presented? Lastly, this is the evaluation of framework for mostly used in network. This framework is to evaluate the program in the community settings. This is to check the effectiveness, adoption, implementation and maintenance framework, and the goal is to improve the sustainable adoption and implement effective, generalizable and evidence-based practice.